I'm Dr. Guru Sonpadve. I'm the Director of GU Oncology and Phase 1 Clinical Research at the Advent Health Cancer Institute in Orlando, Florida, and I'm here to talk about GU Oncology highlights from ASCO 2023. So first, let's discuss urothelial carcinoma highlights. As we all know, the landscape of therapy for urothelial carcinoma has changed a lot over the past few years. In most patients in the first-line metastatic disease setting, we offer platinum-based chemotherapy and then going to switch maintenance avelumab PD-L1 inhibitor therapy in patients with stable or responding disease. And in patients who are cisplatin ineligible, we do have the option of enfortumab vedotin plus pembrolizumab available based on non-randomized data phase 1b trial, as well as a small randomized phase 2 trial, which led to accelerated US approval recently. Now, also in platinum ineligible patients, which is essentially chemotherapy ineligible patients, we have pembrolizumab available as monotherapy, and this is regardless of PD-L1 status. Now, in the salvage setting, we have several options available in patients following platinum and PD-L1 inhibition, and these include enfortumab vedotin and erdafitinib in patients with FGFR2, FGFR3 activating mutations or fusions. And we also have enfortumab vedotin approved in cisplatin ineligible patients as second-line therapy. Now, in patients who are post-PD-1/L1 inhibition as first-line therapy, you do have the option of gemcitabine carboplatin because these patients are likely cisplatin ineligible, as well as enfortumab vedotin. Now, in both post-platinum and PD-1/L1 inhibitor exposed patients, we have multiple options, including the antibody-drug conjugates, enfortumab vedotin, sacituzumab govitecan, and erdafitinib. And in the late salvage setting, we still have the availability of taxanes in the US, and in other countries, vinflunine is available in these late-stage patients. Now, as an update at ASCO 2023, the THOR phase 3 trial was presented. This is a study done in patients with somatic FGFR3 or FGFR2 activating mutations or fusions. And so this is a randomized phase 3 trial done in patients who were post-PD-1/L1 inhibitor exposed. The patients were randomized to erdafitinib, the pan-FGFR inhibitor, or a chemotherapy of choice, which could be taxane or vinflunine. And so the primary endpoint was overall survival. And so this trial was positive essentially. So what was shown was overall survival was extended with a hazard ratio that was 0.64. The median survival was 12.1 months for erdafitinib versus 7.8 months for the chemotherapy arm. When they looked at several subsets, one of the interesting findings was that patients with the upper tract primary seemed to have a more robust improvement in survival. That's interesting, but it's hypothesis generating and not well powered, as you know, in all of these sub-analyses. They also looked at progression-free survival, and this was also extended with a hazard ratio of 0.58, and the median PFS was extended to 5.6 months with erdafitinib versus 2.7 months for the chemotherapy arm. When they looked at the objective response rate, this was also significantly increased with erdafitinib to 45.6% versus 11.5% for chemotherapy. So this is, again, consistent with what was seen with erdafitinib in the non-randomized phase 2 trial that led to approval in the post-platinum setting some years ago. So these data might lead to full approval of erdafitinib, so we will need to wait and see. There is also another comparison in this phase 3 trial, which is the comparison of a PD-1 inhibitor with erdafitinib. This comparison we just described was erdafitinib versus chemotherapy in post-PD-1/L1 inhibitor patients. So the comparison with PD-1/L1 inhibitor is of interest, and this is still pending. There is another interesting study that was presented at ASCO. This is called the NORSE trial. This is the NORSE randomized phase 2 trial. This again was in patients with the FGFR3, FGFR2 activating mutations or fusions. Again, ASCO was heavy on FGFR3 2 altered patients in bladder cancer. So this study was a first-line study in patients who were cisplatin ineligible and had these FGFR3 or 2 activating mutations or fusions. And this study compared erdafitinib versus erdafitinib plus sertrillimab, which is a PD-1 inhibitor. So again, this is a small randomized phase 2 trial. This was designed to be a non-comparative randomized phase 2 trial with the primary objective response rate and safety. So at the end of the day, what they saw was interesting because there was an objective response rate with erdafitinib of 44.2%, which is what has been seen even in the post-platinum setting and in the just mentioned Thor phase 3 trial, which was in the post-PD-1/L1 inhibitor setting. But the combination of erdafitinib plus sertrillimab yielded an objective response rate of 54.5%. Again, this was designed to be a non-comparative trial, but uh, just looking at the objective response rate, it suggests that there might be an increment when combining erdafitinib with a PD-1 inhibitor in these selected patients for the somatic genomic alterations. So again, this data is interesting but needs further validation in a larger randomized trial. Now, one of the data sets that has come out since ASCO and soon after ASCO um, in July of 2023, so this was not at ASCO, but this is a very important finding. So this is the Checkmate 901 phase 3 trial, which had a sub-study which compared gemcitabine cisplatin with gemcitabine cisplatin plus nivolumab. So again, this is cisplatin eligible patients only in the first line setting. And interestingly, this study was positive. The study met the dual primary endpoints of overall survival and progression-free survival in cisplatin eligible patients. So we haven't seen the data yet, so we need to wait and see what the data look like. So potentially we have a chemo immunotherapy regimen, at least for cisplatin eligible patients. As we all know previously, the Keynote 361 trial and the IMvigor 130 trial were both negative, unfortunately, for combining different PD-1/L1 inhibitors with platinum-based chemotherapy. And those trials were done in both cisplatin eligible and cisplatin ineligible patients, as opposed to this trial, Checkmate 901, which was done dedicated to cisplatin eligible patients. So really, all of these changes will are eagerly awaited. As we wait for the data to mature and see what the regulatory agencies say based on what the data look like. So again, maybe gemcitabine cisplatin nivolumab will be there in the first line cisplatin eligible space. We don't know. The other really interesting trial that we are waiting for eagerly is the EV302 trial, which is comparing EV plus pembrolizumab versus gemcitabine platinum in both cisplatin eligible and cisplatin ineligible patients. So again, that is a very important trial, but because that could potentially bring EV plus pembrolizumab to both cisplatin eligible and ineligible patients in the first line metastatic disease setting. And then next, I wanted to highlight the VESPER trial. The VESPER trial was presented at ASCO as an update. This is the trial done by the French GETUG group, which looked at perioperative gemcitabine cisplatin versus dose-dense MVAC. They compared 4 cycles of gemcitabine cisplatin versus 6 cycles of dose-dense MVAC. And essentially, the primary endpoint of progression-free survival was not met in the overall group. But at ASCO, they had an update where they looked at overall survival, and they saw a similar finding, which is basically the primary outcome as shown at ASCO of the overall survival was not met in the overall group. But interestingly, in the neoadjuvant group, which was the vast majority of patients, about 88% of patients, there was an improvement in overall survival for dose-dense MVAC versus gemcitabine cisplatin. So this is similar to what was presented some time back at ESMO, showing an improvement with dose-dense MVAC given for 6 cycles over gemcitabine cisplatin in the neoadjuvant group only. So these data are interesting, and in the community, I think we mostly have used 4 cycles of gemcitabine cisplatin or dose-dense MVAC, also given for 4 cycles interchangeably. So I think that these data are also informing practice.